morning, everyone. Today we are going to discuss about congenital heart diseases. Congenital heart diseases are the structural defects that are present at the time of birth. Before going to start about these congenital defects, let's see about the normal structure of heart. So in the normal structure of that, the heart comprises of 4 chambers: right atrium, right ventricle, left atrium, and left ventricle. So this right atrium and left atrium were divided through the septum that is called as atrial septum, and right ventricle and left ventricle is divided through a septum that is called as ventricular septum, and both atrium and ventriculars are divided through atrioventricular septum. Okay, so the right atrium receives deoxygenated blood from whole parts of body. Through upper parts of the body, the superior vena cava drains deoxygenated blood into right atrium, and the inferior vena cava drains deoxygenated blood from lower parts of the body into the right atrium. From right atrium, the blood moves into the right ventricle through tricuspid valve. Here you can see it has 3 cusps, hence it is known as tricuspid valve. The blood from right ventricle it moved into the pulmonary trunk. So through pulmonic valve. These pulmonic valves were in half moon shape. Hence these are termed as known as semilunar valves. So the deoxygenated blood from pulmonary trunk was moved into the lungs through right pulmonary artery and left pulmonary artery. So in the lungs, the oxygenation of blood will be taken place. And the oxygenated blood from lungs, from the right lung through and left lung, each lung carries 2 pulmonary veins. Right lung carries right inferior pulmonary vein and right superior pulmonary vein. And the left lung carries left inferior pulmonary vein and left superior pulmonary vein. All 4 pulmonary veins carries oxygenated blood from lungs and it drains into left atrium. So from left atrium, the oxygenated blood is moved into the left ventricle through bicuspid valve, or the bicuspid valve is also known as mitral valve. The oxygenated blood from the left ventricle moves into the aorta through aortic valve. These aortic valves are also in semilunar in shape. Hence, these were also called as semilunar valves. And the aorta goes up as ascending aorta and it bends at arch of aorta and it descends like descending aorta. The descending aorta later moves into the thoracic cavity as thoracic aorta and in abdominal cavity as abdominal aorta and drains blood to whole parts of the body. And we see fetal circulation. In fetal circulation, normally in adults, the oxygenated part is lungs. But in case of fetus, the lungs were not the part of oxygenation, or respiration won't be taken place in the lung. The primary or fundamental function of the lungs is respiration, but in fetus, the primary function of lungs is not done. The primary function of respiration is done through placenta. The placenta, here in the placenta, the oxygenated blood is carried from the umbilical vein through umbilicus and it goes towards the liver. And at the liver, it bifurcates into 2 parts. One part, the right part, it mixes with the portal circulation and later it will be drained into inferior vena cava. The other part will directly drains into the inferior vena cava through ductus venosus. The ductus venosus, it moves into inferior vena cava. The inferior vena cava already carries the deoxygenated blood from lower parts of the fetus. And here the blood is mixed. The oxygenated blood from the umbilical vein and the deoxygenated blood from the inferior vena cava were mixed, and this mixed blood was opened into or drained into right atrium. As we know, then normally the blood from right atrium should move into the right ventricle, and then from right ventricle to the pulmonary arteries, and from pulmonary arteries to the lungs. As the lungs were not the respiratory organs here, the pulmonary circulation is high compared to the systemic circulation. Hence, the pressure inside the pulmonary trunk will be high, that creates pressure, more pressure in the right ventricle, and in reverse that creates more pressure in the right atrium. There is a opening between right atrium and left atrium in the atrial septum, that is known as foramen of Owen. As we will discuss now, the pressure inside the right side of the heart is more compared to the left side of the heart. The blood moves from right atrium to the left atrium, and the blood from the left atrium is moved to the left ventricle, and from left ventricle the blood moves into the aorta, which carries the blood to all parts of the body. Some of the blood which is moved into the right ventricle is, and that moves into the pulmonary trunk, will be moved to the aorta through ductus arteriosus, because the pressure in, as we discussed earlier, the pressure inside the pulmonary trunk is more compared to the aorta. Hence the blood from pulmonary trunk is moved into the aorta, and whole blood will be shifted to all parts of the body. And the abdominal aorta, later iliac arteries. From iliac arteries to umbilical arteries carries blood back to the placenta for oxygenation. So this is normal fetal circulation. And let's see the changes after birth. The immediately after the birth, what will happen? The lungs starts expanding, means the lungs becomes the respiratory organ in the feed, in the baby. So as soon as the lungs starts getting respiration, the pulmonary resistance, which is high in the fetal period, will become less. So as the pulmonary resistance is decreased and systemic resistance is increased, the blood which is moved from right atrium to left atrium through foramen of Owen will stop. The blood from right atrium is moved, instead the blood from right atrium is moved into the right ventricle, and from right ventricle to pulmonary trunk, and from pulmonary trunk to lungs, back to the lungs. But earlier it was not like that. Yes, right? And now the from the lungs, the oxygenated blood will be moved back into the left atrium, and from left atrium to left ventricle, and from left ventricle to aorta, and the aorta carries blood. Here, earlier, as the pulmonary resistance is more, the blood is moved from pulmonary trunk to the aorta through ductus arteriosus. But now, as the pulmonary resistance is decreased compared to the systemic resistance, the blood won't be shunted here. So here, immediately after birth, the umbilical vein will be converted into ligamentum teres, and umbilical arterioles, ductus arteriosus will be closed, and foramen of Owen also will be closed, because these structures, these structures like umbilical veins, ductus arteriosus, ductus venosus, pulmonary, foramen of Owen, these all parts were structurally no need after birth. So these will be pulmonary closed. And now see, so in all congenital heart defects, the manifestations where the cardiac output will be decreased. So these cardiac output, because of the decreased cardiac outputs, let's see the manifestations. So as the cardiac output is decreased, that leads to decreased blood supply to the all parts of the body. When there is decreased blood supply to all parts of the body, automatically that leads to hypoxia, which causes activity intolerance. As the cardiac output is increased enough, the blood is not pumped into the arteries with enough pressure, that leads to decreased peripheral pulses, and the baby will be landed with feeding difficulties, and the baby will have hypotension, irritability, restlessness, and the baby will become lethargic. These are all the symptoms of hypoxia. As there is decreased cardiac output, automatically the blood flow to the kidney is also decreased. That leads to oliguria. And as there is decreased cardiac output, the metabolism, the blood flow to the all parts of the body will be decreased. That leads to decreased metabolic rate, and the temperature will be decreased. That leads to cool extremities, and the extremities will become pale. As a compensatory mechanism for the decreased cardiac output, the heart tends to beat fast. So that lands with tachycardia. And these congenital heart defects will be manifested as heart failure. So let's see the manifestations of right side heart failure and left side heart failure. The left side heart failure, as the left side heart failure, the left ventricle can't able to pump blood from the left ventricle. Hence, the blood will be stagnated inside the left ventricle. That leads to left ventricular hypertrophy, and there will be reverse increased resistance in the left atrium. That leads to increased resistance in the pulmonary trunk. So sorry, pulmonary veins, and that increases pulmonary hypertension, and pulmonary that causes pulmonary edema. Because of pulmonary edema, there will be tracheal wheezes and cough, dyspnea, grunting, head bobbing, nasal flaring, orthopnea, periods of cyanosis, retractions, and tachypnea. So these are all the symptoms: grunting, nasal flaring, retractions, tachypnea. These are all the symptoms of respiratory distress. Hence, in the left side heart failure, there will be symptoms of respiratory distress along with crackles, wheeze, cough, dyspnea, head bob. And in the right side of heart failure, the right ventricle can't able to pump blood outside. That in turn increases blood in the right atrium. That increases the pulmonary resistance. Because of increased systemic resistance. Because of this, there will be reverse increase in the pressure in the inferior vena cava and superior vena cava. That leads to the increased pressure in the superior vena cava leads to jugular venous distension, and increased pressure in the inferior vena causes hepatosplenomegaly, ascites, peripheral edema, dependent edema, and periorbital edema. Along with this, we can see oliguria and weight gain. And the classification of congenital heart diseases. The congenital heart diseases are classified into two types: cyanotic heart diseases and acyanotic heart diseases. The acyanotic heart diseases are further classified into two categories, which has increased pulmonary blood flow. Those are atrial septal defect, ventricular septal defect, patent ductus arteriosus, and atrioventricular canal defect. And the acyanotic heart disease with obstruction of blood flow from the ventricles were coarctation of aorta, aortic stenosis, and pulmonic stenosis. And the cyanotic heart diseases with decreased pulmonary blood flow were tetralogy of Fallot, tricuspid atresia. And the cyanotic heart diseases with mixed blood flow was transposition of gate arteries, total anomalous pulmonary venous return, truncus arteriosus, hypoplastic left heart syndrome. Let's see each disease condition, each congenital heart defect separately. This is atrial septal defect. Normally, the heart is divided into 4 chambers, and both atria were separated by atrial septum. But here, as we know earlier, there is opening between right atrium and left atrium, that is foramen of oval. If the opening after birth, if the opening is at the foramen of oval, that is called as ostium premium. If it is below, that is called as ostium secundum. If the opening is at the opening of coronary sinuses, that is sinus venous defect. So here, atrial septal defect, it is the abnormal opening between the two atriums, right atrium and left atrium. What happens here in the atrial septal defect? As we know, the right side of the heart, the pressure in the right side of the heart is less compared to the left side of the heart. the oxygenated blood from the left side of the heart will be shunted into the right side. There will be left to right shunt that increases the blood flow to the lungs, because the oxygenated blood from left atrium is moved into the right atrium. From the right atrium, the blood will move into the right ventricle, and from right ventricle, the blood automatically should move to the lungs. So this causes increased blood flow to the lungs. The management. So here usually the child with atrial septal defect will be asymptomatic based on the size of the defect. And if the size of the defect is too large, the child will manifest with the symptoms of heart failure. The manifestations will related to decreased cardiac output may be present. And the management will be defect may be closed through cardiac catheterization. So here this defect can be closed to the cardiac catheterization, and open repair of the coronary bypass grafting may be done. Next, we'll see ventricular septal defect. Ventricular septal defect, the abnormal opening between the two ventricles, right ventricle and left ventricle. So this ventricular septal defect may be from the small size to the complete absence of the septum. It may be very like a pinhole, or it may be complete absence of the septum. As we know, the right side of the heart has less pressure compared to the left side of the heart. During cardiac cycle, during ventricular contraction, the blood from the left ventricle is shifted into the right ventricle. That causes increased blood flow to the pulmonary trunk. So here the symptoms may be similar to the symptoms of heart failure. The child with ventricular septum is manifested with characteristic murmur, and management will be we have closed the defect through cardiac catheterization, or open repair can be done through cardiopulmonary bypass. And next, we'll see patent ductus arteriosus. We know the patent ductus arteriosus is the connection between arch of aorta and pulmonary trunk. So earlier, the blood as the pulmonary resistance is more, the blood from the pulmonary trunk is moved into the aorta, right? But now after birth, the systemic circulation, the pressure inside the aorta is more compared to the pulmonary trunk. The blood from the aorta is moved into the pulmonary trunk, and that increases the increased blood flow to the lungs. Okay, and these patent ductus arteriosus, the child with patent ductus arteriosus is manifested with characteristic missionary-like murmur. This is the NCLEX question. This is very important. The child with patent ductus arteriosus is manifested with missionary-like murmur. An infant may be asymptomatic and may show signs and symptoms of heart failure, and the infant may show widened pulse pressure and bounding pressure pulses. And the management is the supplementation of indomethacin. The indomethacin is a prostaglandin inhibitor. This prostaglandin inhibitor is given so that the ductus arteriosus will get closed. The cell division in there will be enhanced through the prostaglandins that closes the ductus arteriosus, and the defect may be close to the cardiac catheterization, and prostaglandin E may be used to keep the patent ductus arteriosus open when it is associated with other defects. Usually indomethacin enhances the closure of ductus arteriosus, and prostaglandin E promotes keeps the ductus arteriosus open. And next, atrioventricular canal defect. The atrium and ventricle separated by atrioventricular canal. The septum has whole the septum will has the defect. Hence, the blood, as we know, the pressure in the left side of the heart is more compared to the right side of the heart. That leads to movement of the oxygenated from blood from left side of the heart to the right side. That increases the blood flow to the lungs. And here, this atrioventricular canal defect is associated with Down syndrome. This is also a NCLEX question. The defect that is associated with Down syndrome is atrioventricular canal defect. This also will have characteristic murmurs. The infant usually have moderate or mild to moderate heart failure symptoms and cyanosis with increasing of the cry. And the management will be pulmonary, the palliative management will be seen here, pulmonary artery banding. When we do pulmonary artery banding here, we are increasing the pressure, automatically we are increasing the pressure in the right side, that decreases the shunting of the blood from left to right. Hence, we are going to do the pulmonary artery banding. And complete repair can be done through the pulmonary cardiopulmonary bypass grafting. And the next disease is aortic stenosis. In the aortic stenosis, aortic valve is the one which is present between left ventricle and aorta. So when there is aortic stenosis, that narrows the, or that gets squeezed and that decreases the left ventricular output. It does not allow free movement of blood from the left ventricle to aorta. So this valvular stenosis is common type, usually caused by malformation of the cusps. That semilunar cups will not be formed clearly. And this also has the characteristic murmur. And the management will be dilated or narrowed valve may be done during cardiac catheterization through PTCA, percutaneous cardiac angiography. So here, through the balloon dilatation will be done through balloon cardiac catheterization, or surgical valvotomy can be done, and valve replacement can be done in this to replace the aortic valve. Next, poietication of aorta. So here, the ascending aorta, this is ascending aorta and it bends as arch of aorta, and later it goes as descending aorta. The ascending aorta has three structures or supplies three blood vessels. One is brachiocephalic. Brachio is hand, right? Cephalic is head. This brachiocephalic supplies blood to right side of heart. Sorry, right side of head. So brachiocephalic lateral divided into right subclavian that supplies blood to the right hand, and right common carotid that supplies blood to right side of the head. And next, left common carotid that supplies blood to left side of the head, and left subclavian that supplies blood to the left side of the hand. So here we will see coartication, that is narrowing of the aorta. When there is narrowing of the aorta, the pressure distal to the defect will be decreased, and pressure proximal to the defect will be increased, right? So with this increased pressure proximal to the defect, here the proximal to the defect, the aorta is supplying blood to head and arms, upper extremities. Hence, the blood pressure in the head and upper extremities will be more, and the blood pressure in the lower extremities will be less. Here, the characteristic symptom here will be, there will be strong pulses in the upper extremities. If you feel the radial pulse, it will be very strong, and compared to the distal pulses. So, sorry, coartication of aorta. The blood pressure is higher in the upper extremities rather than lower extremities. This is NCLEX question. It's very important. The defect, the congenital defect, which is manifested with high blood pressure in the upper extremities and low pressure in the lower extremities, on bounding pulse in the arms and weak pressure in the femoral pulses, is coarctation of aorta. And here we have to, the management will be done via balloon angioplasty. So balloon angioplasty will be done, and this coarctation will be, the narrowed part will be widened, and resection of the part will be done, or if not balloon angioplasty, if not that, surgical management will be done through resection of the part will be done, and the end-to-end anastomosis will be done. So using a graft, or else end-to-end anastomosis also can be done. So here, because the graft is outside the heart, cardiobypass surgery is not required. Thoracotomy incision is used. So with minimal thoracotomy procedure, we can correct this coarctation of aorta. Okay.